In this next section, we're going to talk about how this all comes about, and how we can actually begin to discuss and discover where a person is spiritually. Before we do that, let's take a look at some interviews we did with some doctors a few years ago.
And one of my favorite writers is Oswald Chambers, and he said, oftentimes the most spiritual impact that you have is when you realize it the least. And it can be just a cup of cold water or a passing comment, but that person is ripe and ready for that little piece of the puzzle to be put into place to make it all make sense.
On the other hand, I've seen the seeds that we've planted bear fruit later on in people's lives in other situations, and really have to remind myself that it really isn't about me, it's about what God wants to do in their life.
I'd say with greater humility, and realize that the Holy Spirit will work with whoever God chooses to work with. And we're just the vehicle, we're just the conduit.
Over the years, I've had a greater confidence to approach patients about spiritual things, and I have a much greater satisfaction as a result of saying, I'm just trying to be faithful. Something that I heard a long time ago, one of the things that intimidates people about sharing their faith, I think, is feeling as though they have to be perfect, number one, and have the perfect communication. Right. And instead, something that helped me, John MacArthur said years ago, sharing the gospel is much like being a waiter. Just get the food to the table. If the patron doesn't like the food, it's really a problem with the cook, not the waiter. Yeah. Although sometimes they take it out on the waiter, and that's given me great confidence as I just keep thinking, get the food to the table, and don't worry about the response.
And if they're hungry, they will.
If they're hungry, they'll eat. And if they have a problem, they'll take it up with the cook.
There you go. Well, we're going to start moving into the spiritual interventions. This is going to be our first one. Is going to be the concept of a spiritual assessment, spiritual history. And I want you to be comfortable just sort of absorbing this information. There's a few blanks that we'll be filling out, but the most part, I want you to just get a kind of a sense of the science, the data behind this. And most everything I'm going to tell you is in a two-part article that was published this year and is printed in the back of your workbook. The basics of spiritual history, and then the newest spiritual history that we've been teaching. But if you would like a longer version of either of those articles that has more literature and more citations, that's available at cmda.org/spiritual assessment. Those are not case sensitive. And you're free to copy those, print those off, use them, share them with others. And let me use that as a reminder to say you're also welcome to use any of the information that we're giving you this weekend. You can copy it, plagiarize it, steal it, publish it. It doesn't matter. It's freely received and it's freely given. And feel free to use it and share it with others. This course is available in a video format, and so if you decide that one of your take-home applications is that you would like to perhaps form a group together, that you could go through this information together once a week over 12 weeks or once a month over a year, and do this as a group, that's available from CMDA. And they've just announced that they hope to have all of these different modules available on the internet for no charge, probably starting next summer. So information is available to all of you. Also, the very last page of your workbook is an evaluation sheet. And besides just filling that out at the end, if there's a particular session that you think, they shouldn't teach that anymore, boy, what a waste of time. Not put that down in your evaluation. Or if there's a session that you like, or any particular information that you think would be helpful to us, it'll come back to us anonymously, and we would really would enjoy receiving that critique from you. So there's both academic and practical reasons for a spiritual history, a spiritual assessment. Koenig, the psychiatrist at Duke, says that the academic reasons include finding out what's a patient's religious background. If we had time to go through the case, it was a case of a Jehovah's Witness. And not doing a spiritual history to find out that someone is a Jehovah's Witness is of particular importance to surgeons, right? Would you want to operate on someone if you didn't know they were Jehovah's Witness? Well, no. Even a surgeon can understand this, right? Randy's not here for us to kid. So the religious background, the role that religious spiritual beliefs, practices play in coping with an illness or causing distress, with an illness. And as I said earlier, if you don't ask, you simply will not know. Thirdly, any beliefs that influence or conflict with health decisions or health compliance, the Jehovah's Witness being an example there. What is their level of participation in a spiritual community? And how supportive is that community? Or how harmful is that community? And then any spiritual needs that might be present for your patients. So sort of academically, those are some of the academic reasons for a spiritual history, but there's also some very practical reasons. And one is patient desire. Studies have shown that up to 90% of patients want physicians to address their spiritual needs. Now, I want you to be real clear about something, and that is that we're trying as much as we can to use citations from the medical literature. So where it says physicians, we'll use the word physicians. But the data to me is clear that almost everywhere we use the term physician, we could replace healthcare professional. Because the trust that is given to all of us as healthcare professionals allows us to ask things and do things and recommend things that people in normal social situations don't get to ask and don't get to say, because of the trust people give us before we've even earned it, because of being healthcare professionals. In general, the public appears to desire health professionals to inquire about beliefs that are important to them. They're not particularly interested in your pushing your beliefs on them, but they're very interested in you understanding, inquiring about what's important to them, especially as it intersects with healthcare. Secondly, a patient benefit to a spiritual history. In the Handbook of Religion and Health, it says this: assessing and addressing patients' religious or spiritual needs is associated with greater satisfaction of care. Just doing a spiritual history increases the patient satisfaction scores that you'll have. Go figure. 2, 3 simple questions, and their satisfaction with you rises. It's associated with better quality of life measures. What? 2 or 3 questions taking a minute or 2 is associated with better quality of life? How does that happen? I don't know that anyone's explained it, but it seems to be real. Thirdly, less depression. It affects mental health just to ask people where they're at. Fewer unnecessary health services. We now know that spiritual interventions, lower cost of care, better functioning. It enhances the doctor-patient relationship. Now, once again, I think we could say the healthcare professional-patient relationship. But the most recent review in the family medicine literature was an American Family Physician in 2012, and they concluded that assessing patient spirituality can build trust and rapport, broadening the physician-patient relationship, and increasing its effectiveness. Now, irrespective of your spirituality, wouldn't you want to know an intervention that would do all of these things at virtually no cost? It's like carpe diem. Even I'm interested in this type of thing. Assessing and addressing patients' religious and spiritual needs is associated with a better doctor-patient relationship, the Handbook for Religion and Health concluded. And perhaps most importantly, is that a spiritual history allows you to identify risk factors that you have no other way of finding out. I mentioned earlier in an earlier session that religious struggles can predict mortality. There's an inverse association between faith and morbidity and mortality of various types, with a wide variety of diseases and a wide variety of disorders. The first study that I came across that identified this was published out of Duke University, and it was a 2-year study looking at patients that were admitted to med-surg or psychiatric services. And then they were followed for 2 years after discharge from the hospital. This was an older group of patients. They were 55 and older. I now consider those adolescent patients. Older, 55. I don't think so. But anyway, that's how they define them. And what the study found was they used a 16-point question of religious struggle. And they found that patients that had any religious struggle, and this was a multivariate study that looked at a variety of demographic features, a variety of illness features, of socialization that patients had. There was a 6% increase in mortality over the next 2 years. And I've got to tell you, I sort of thought, I mean, we see a lot of data, and 6%, maybe that's not such a big deal. But then if you look at the 4 factors that had the greatest impact, those 4 factors were associated with a 16 to 28% increase, not morbidity, but of mortality. Now, you've got me interested. If there is a factor that's going to affect post-discharge mortality by up to 1/3, I think I'd sort of be interested in knowing about it. I think you would too. So I call these 4 factors the LAP factors, L-A-P factors. And the first is loved. And the question that was asked at Duke was, does this illness, does this cancer, does this disorder, does this situation that you're wrestling with cause you to question God's love for you or not? Do you use tobacco or not? Do you use alcohol or not? Has this disorder or this disease caused you to question God's love for you? And yes to that, by itself, predicted a 22% increased mortality over the next 2 years post-discharge. There's not a lot of risk factors we see that have that level of impact. The second question was A, for this LAP acrostic. I'm a simple person, so I use simple acrostics. And it is abandoned. The question that they used in the study was, does this disease, does this disorder, does this cancer, does this problem that you're wrestling with cause you to believe that God has abandoned you? And that was associated with a 28% increase in mortality. Now, a variation of that is unpublished, but that you need to be aware of, is that particularly in Christians who come from charismatic backgrounds, a measure of this abandonment is someone who has been taught to ask for healing and has been taught if they ask for healing in a particular way that they will receive it. And if they do not receive it, then it's either because of their lack of faith or that they didn't ask the right way or they have unconfessed sin in their life. And that also is another potential for abandonment, that I've asked God to heal me and he has not. And so abandoned, very high risk for mortality. And then I told you there were 4 factors, and LAP is 3 letters. How do I get 4 and 3? It's this way, because the 2 questions that were asked at Duke were in the area of punishment. And the first was, do you feel punished by God, either for lack of devotion or for wrongdoing in your life, associated with a 16% increase in mortality, or do you feel punished by the devil? The devil did this. The devil caused this. And that was associated with a 19% increase in mortality. So 3 factors that predicted by themselves a 16 to 28% increase in mortality, and I call those the LAP factors. A 2015 study that just came out this year was a study of about 200 adults with a wide variety of chronic conditions, everything from stroke to cancer, a bunch of primary care disorders, spinal cord injury, traumatic brain injury, these sorts of things, showed that people with any degree of negative spiritual belief, and the study author said in particular, feeling abandoned or punished from a higher power in this particular case, that those patients had significantly worse bodily pain, physical health, and mental health, and a lower level of forgiveness. And those of you that are aware of the literature on people who have cynicism and bitterness and anger and unforgiveness and the impact that that has on health can see the importance of a study like this, showing basically people feeling abandoned or punished or not loved have significantly worse health, chronic pain, physical health, emotional health, level of forgiveness. So it's a huge deal that most of us have never been taught about. It's fairly new in the medical literature. And so these particular researchers concluded that any degree, even the most minor degree of negative spiritual belief, irrespective of how strong someone's spirituality scores were, how much positive spirituality they had, irrespective, that these negative beliefs can be associated with worse health outcomes. So Koenig, writing in a editorial in JAMA wrote this, that these patients who are struggling with religious struggle may, without their doctor's encouragement, refuse to speak with clergy. Why? Because they're angry at God. They feel cut off from God. They feel that they've lost this area of support. And so this is one area where pastoral professionals, chaplains, lay ministers won't have access into a patient's spiritual belief system. That door will stay closed. But the healthcare professional, with just very few questions, can open that door, and it's one that will have a significant impact on people. So a growing body of research documents the harmful effects, morbidity, and mortality of religious or spiritual struggle among patients with a wide variety of diagnoses. And it's now considered quality patient care for clinicians to be attentive of, to ask about signs of spiritual struggle. And we'll come back to exactly how to do that in just a few moments. Fifthly, a spiritual history can enhance health care. Dale Matthews and a group of physicians in Washington, D.C. did a systematic review of what the literature says about the relationship of physical, emotional health with spiritual health, and they concluded this: the available data suggests that practitioners who make big changes, practitioners that take a lot of time, practitioners that spend a lot of time, what's he say? That practitioners who make several small changes in how patients' religious commitments are broached in clinical practice may enhance healthcare outcomes. When they submitted this study, Dale said that their conclusion was not that it may enhance healthcare outcomes, but that it will enhance healthcare outcomes. But as a condition of publication, they had to switch it to may enhance healthcare outcomes. And finally, a spiritual history is considered a standard of care for all healthcare professionals, not just Christian healthcare professionals. So spiritual history is required by the Joint Commission for patients cared for in hospitals or nursing homes, not just admitted from the emergency room, but cared for in the emergency room, Bill. So you actually had it right, in the emergency room. For inpatient and outpatient mental health care services, for example, for patients cared for by home health agencies or hospice organizations. And why in the world would the Joint Commission require such a thing? Well, they say that a spiritual history should, at a minimum, determine the patient's denomination, beliefs, and what spiritual practices are important to them. Sort of the diagnostic rubric of finding out where is someone on their spiritual journey. That's what a spiritual history does. The Joint Commission says that this information would assist in determining the impact of spirituality, if any, on the care and our services being provided, and will identify if any further assessment is needed. So the ability to identify and address patients' spiritual needs is now considered an important clinical competency. And that statement was made from the internal medicine literature. I've also put the most recent Joint Commission regulations into your workbook. They're there so that you can access them. I was speaking up in Pennsylvania recently at a large healthcare system, and when I was giving this data, the COO of the hospital, who's not a healthcare professional, he's just responsible for all the financing of the hospital, came up and he said, "Where are those regulations? Where are those regulations?" I said, "Why?" And he said, "We don't get paid if we're not Joint Commission certified. All Medicare and Medicaid funding and many insurance companies depend upon will not reimburse organizations that aren't Joint Commission certified." And so for whether it's inpatient or outpatient facilities who seek that certification, knowing about a spiritual history and the requirements is going to be an extremely important thing for them. Now, there's a variety of spiritual assessment tools that have been published in the literature, over 300 of them. Some of them are as many as 300, 350 questions. And so all you have to do is find one of those that has 300 and just put that into your social history of each patient that comes to your practice. And you got time for that? You got time for 30 questions? Elaine's dog's getting upset with mentioning. I was part of a teaching practice for years, and So we would do a variety of studies, and one of the studies that we did was, I finally just got so irritated with people that would say what we should do in practice. You should do this, you should do this, you should do this. And so one of these regulations came out for pediatric patients, and it just was a tipping point for me. I was just over it. So what we did was we went through all of the national guidelines and found all the recommendations for every child that was there for a well-child visit. And then we took a variety of clinicians and said, for each of these interventions, how long would it take you? 1 minute, 3 minutes, 5 minutes, or whatever. And we added up the average and mean scores, and we found that if we did what everybody told us to do with every well baby visit, it would take 182 minutes. You got time for that? Not me. Forget the 300-word questionnaires. I've just put questionnaires in here that are 3, 4, or 5 questions long for you to use. And they're found on pages 39 to 42 of your workbook. So I'm not suggesting you use any one of them. I'm suggesting that you look through them and see, are there 2 or 3 questions here that would fit you, fit your temperament, fit your personality, fit your style, fit your niche in healthcare in such a way that these would be questions that you could add to your social history. When you're asking patients about tobacco use and alcohol abuse and where they work and what's going on with them socially. One of the most recent in the literature is called the Open Invite system, and it just says, as part of your social history, just open the door to spiritual conversation. In this article, they suggest questions like, may I ask about your faith background? Or, do you have a spiritual or faith preference? If someone says yes, they've opened the door a little bit for you to explore. If they say no, you know that that's something that's not important to them or something they want to talk about. And then after the opening is just invite the patient to discuss spiritual needs using a mnemonic, is what the authors recommend. So all I've put in your workbook are mnemonic-based spiritual histories, the faith history, the hope history, the spirit history, the CSI memo history are just a few examples. But the one that we taught for years, that's been taught in Saline Solution, International Saline Solution, in METS conferences, and in early Grace prescription conferences, were just the God questions. Simply the GOD questions. So the G part of the acrostic is God, spirituality, faith, something that's important to you or not. People may say yes, they may say no. If they say yes, you can ask a follow-up question. It'd be no different than if you're asking someone about, do you use tobacco? And they say yes. And you say, well, what do you use and how much? Pope smoked 16 packs a day, been doing it 86 years. Granny did it till 190, No's a no, yes. Do you use alcohol products? Yes. How much, how often? Do you do? Is God, spirituality, faith, religion something that's important to you or not? Yes. Tell me a little bit more about that. The O is others. Do you now or have you in the past met with others in a spiritual or religious community? No is no. Yes is yes. Tell me a little bit more about that. And the D that we taught for so many years was do. What can I do to assist you? Are there any spiritual resources that you might need? Would you want me to pray for you? Would you want me to pray with you? Whatever the do might be. Is there anything in your religious tradition? I may not be familiar with your religious tradition. Is there anything in your tradition I need to know as I care for you? So the D is the God. G is God. O is others. The D is you. But we're sort of missing an important factor here, and that's simply the religious struggle questions. They weren't there. As I think back to, I've been using spiritual history since 1988, so as I think back over the last 30 plus years of using spiritual histories, I cannot remember a single patient who told me about religious struggle. I didn't ask, and they didn't tell me. Since I've started both in my practice and with the residents that I teach, using this new spiritual history I'm going to tell you about, it's running about 1 in 5, about 20% of our patients. And the literature says it runs anywhere between 10% and 25% of patients that we see are wrestling with religious struggle. And we've never known how to ask. So when I began to realize the importance of this, I developed a new spiritual history that I call the Lord's Lap. And it's in the second article that's in the back of your book, but it's the one that we're going to not only spend some time with tonight, but we're actually going to practice with each other. I'm not suggesting that you use this one, but I want you to get a sense of what it feels like to ask people these questions here in just a few minutes. So the Lord part of the acrostic, L-O-R-D, now those of you that are really sharp and really fast can actually see the God acrostic in here, right? G-O-D is the L-O-D. And there's a new R, which is religious struggle or relationship. Now, as I go through this, there's a couple of ways that you can do it in your workbook. One is you can go right along with the text in your workbook. That's pages 42 to 43. Or you can look at the flow sheet in your workbook and follow along. But I'd suggest one or the other. If you're more graphical, you may want to go to page 45. If you're more textual, go to page 42. So the Lord questions, the L of the Lord acrostic is exactly the same as the G of the God acrostic. May I ask about your faith background? Do you have a spiritual faith or preference? Is God, spirituality, religion something that's important to you or not? Now, I will tell you that when I teach residents and when we round in the hospital, that up until just the last 6 months or so, I was very favorable to the open question, which was to say, would you mind if I ask you a couple of questions about your faith preference? Two things have changed that practice. One is, no one ever said no. I never had a single person say no. In fact, it heralds back to early on in 1988 when I started doing these, and I expected to have some resistance from patients. And my spiritual mentor was a fellow named Bill Judge. Bill's a dairy farmer and still is my mentor. I talk to him once every week or two by phone. But I was reflecting to Bill that I was asking these questions and patients were not wrinkling their eyebrows. They weren't concerned. They weren't showing any upset at all. And he said, well, did you expect them to? And I said, I did. And he said, why? And I said, because these are like strange questions. And he said, well, you guys ask a lot of strange questions anyway. And I got defensive. I was like what? Like what? And he said, well, like I've been married to Jane for 42 years, and I came in for my preventive medicine visit this year, and your nurse asked me how many sexual partners I had the last year. So that was a strange question. But I figured you had a reason. I figured there was a reason for that. So I thought about it, and I figured the answer was either 0 or 1, but I don't think you have to ask the open question. May I ask about your faith preferences? But as you begin to get used to doing this, that's something that you could do. Say, may I ask about your faith or religious preferences? Do you have a preference? Is God faith? So that's the L part of the question. The O is the same as the God questions, and that's others. Are you now, have you in the past been part of a religious or spiritual community? If yes, how do you incorporate it into that? Is it like the guy I told you about earlier that goes religiously twice a year because his wife makes him? Or is it someone who goes Sunday morning, Sunday night, Monday night, and Wednesday night? I had a lady tell me recently, she said, because I was asking her about, is God, faith, religion, spirituality important to you? She said, oh, my relationship with God through the blood of Jesus is the most important thing in my life. Okay. Are you now, have you ever been in the past part of a spiritual or religious community? She says, oh, yes. She says, I go to church every Sunday morning, every Sunday night, every Monday night, Tuesday night, and Wednesday night. She said, and she kept going, she said, because if you just go Sunday morning, you only love your church. And if you just go Sunday morning and Sunday night, then you just really only love the pastor. But if you go Sunday morning, Sunday night, Monday night, Tuesday night, and Wednesday night, then you do love Jesus. Now, this is the same woman who said the bigger the hair, the closer to Jesus. So, but you learn something about the patient. So those are sort of the L and O questions. And the R is the religious struggle or relationship questions. So after you do the L and the O questions, you're going to have a good idea of whether religion or spirituality is something that's important to that patient. And I'm not talking about them being Christian or not Christian, just whether religion or spirituality is important to them. And you'll also have an idea if it's of no importance at all. Had a big old truck driver, I'll call him Bob, and so I was doing his social history, and then when I got to the spiritual history, I said, is God, faith, religion something that's important to you or not? And he said, hell no. And then, are you now, are you ever, I mean, it's sort of like, do you smoke? Hell no. You know, okay. The O is, are you now, you ever been part of a spiritual community, a religious community? And he said, blankety blank, no. And I didn't ask any D questions. I mean, it's kind of, you know, he's not of the religious persuasion. The ground's kind of hard there, right? You know where he's at spiritually. So after L and O, you get an idea if spirituality or religion is something that's important to them or not. For the person to whom religion or spirituality is important, irrespective of the brand, they're a candidate for the religious struggle questions. So if your patient is religious or claims to be religious, then religious struggle, there's an indication to support that. And the mnemonic I think of is just looking at the patient saying, okay, you're religious, but are you in the Lord's lap? Or have you fallen out of the Lord's lap? Or maybe you never were in the Lord's lap. So are you in the Lord's lap, or have you fallen out of the Lord's lap? And you simply can ask the lap questions to find out. So the L is love, right? So has this disorder, this illness caused you to question God's love for you? The A is the abandon. Has this illness led you to believe God has abandoned you? Or have you asked for healing and not received it? Is a spur question you can use there. And the P is, do you believe God or the devil's punishing you? If the patient answers yes to any of these, then the current literature is that they deserve a referral, a consultation with a pastoral professional or a chaplain. That this is not, there's some deep water lane here, isn't there, when we have patients dealing with that. And most of us don't have the training or experience to deal with that. But because of the association with morbidity and mortality, it would be foolish of us not to enter that into the problem list and not to help that patient seek help. By the way, in both ICD-9 and ICD-10, there are codes for religious struggle and also for counseling for religious struggle. Now, suppose your patient's not religious, not spiritual. Then the religious struggle questions aren't indicated. It's fine to move on. But here's a point in the spiritual history where you can let them know you're in the Lord's lap. That you can share either a testimony, a faith story, or a faith flag about your relationship with God. And so an option to do this is just if the patient says, no, I don't have a relationship with God. Religion and spirituality is not important to me. I've never been part of a social community. Hey, thanks for sharing that with me, because it can be hard to talk about these types of things. So just to recognize with the patient, this is tough stuff to talk about. And then you have an option to share a faith story or faith flag if you feel the Holy Spirit leading you to do that. The faith flag could be something as simple as, I often see patients who, when they're beginning to wrestle with a medical or a health problem, will begin to think about spiritual things, or they'll begin to think about eternal things. If you find yourself thinking about those things, let me know. I'll be happy to talk to you. And you move on. It's just a little faith flag. And we'll talk tomorrow morning more about faith flags, but just to introduce it. Because we know, even from the dental literature, that patients who go to the dentist just with an abscess begin to think about spiritual issues. We know that patients who become pregnant begin to think about eternity and spiritual issues. Young couples, when they get pregnant, will begin to think about should they join a spiritual community or not. So illness and health begin to arouse senses of empty hearts and of lack of wholeness, and lack of satisfaction. Eternal questions begin to come up. And even if they are not expressed in the initial history, they can often be expressed at a second visit or a third visit because you simply opened the door to let the patient know you were willing to talk about that. And they may indeed bring it up at a later time. A faith story may be, appreciate you sharing that. It's hard to talk about religious things. And in my case, I might just say, but I want you to know that as I care for you, the most important relationship in my life is my personal relationship with God. And it impacts the way that I care for patients. I might say, Barb and I pray for my patients. Would that be okay? I mean, I'm not, this isn't a technique. It's not something I do with every patient, but just depending on how the Spirit is leading. Hey, listen, this is tough stuff to talk about. I know spirituality is not important to you, but I want you to know that it is for me. And one of the things I do every day before I start clinic is I ask God to give me wisdom and guidance as he cares for my patients. And I'll do the same as I care for you and move on. And it may be that doesn't fit you, but that's okay. It's just to ask is, how would I fit this into what I'm doing? So after the LOR is the D. It's the same as the God questions. Can I do anything to assist you in incorporating your spirituality into your care? Are there any resources that you might need? May I pray with you? May I pray for you? Whatever the questions might be. So to look at it in the graphical sense during your routine social history is asking the Lord questions. So starting with L and O and realizing that either one or both of those is going to be positive, and if so, that's a patient to whom religion and spirituality is positive. If negative, they're not religious. And for the patient who answers positively to one of those two, they've got the risk of, apparently it's somewhere between a 1 in 5 and 1 in 10 risk of religious struggle. And here in New York, it may even be higher than that. You'll have to find out as you apply this information to the patients that you see. But for those patients, asking the LAP questions, 1, 2, 3, the LAP questions, if one or more of those are positive, that's a referral. It's indicated to a mental health professional, preferably an evangelical pastoral professional or chaplain who you trust to counsel patients in this area. But it also can be pastoral professionals of other religions who have chaplaincy training depending upon the religion of the patient. If all three are negative, there's no religious struggle and you can move on. What about the patient who is not religious? That's the one that you have the opportunity to raise a faith flag or a faith story if you feel led, or if not, you can just do the what can I do to assist you. Now on page 44 of your workbook are some additional tips we're not going to go through now, but some tips on listening compassionately, on respecting where people are if they come from a totally different religious perspective, and then clarifying those differences, and then remembering to document. As we talk about all of these spiritual interventions, we're going to encourage you to be sure that you document those as part of the patient record. But there is that new ICD-10 CM code Z65.8 for patients dealing with religious struggle. So remember to document. Word of caution, don't be pushy, but don't ignore a patient's spirituality. So professional problems can occur when well-meaning physicians faith push a patient opposed to discussing religion. However, rather than ignoring faith completely with all patients, most of whom want to discuss it, we've already learned, physicians might ask a question to discern who would like to pursue it and who would not. One review concluded that assessing and integrating patient spirituality into the healthcare encounter can build trust and rapport, broadening the physician-patient relationship and increasing its effectiveness. But Bill and I would say, even more important, the spiritual history allows us as Christian health professionals, as followers of Jesus, to find out where someone is on their spiritual journey so that we can join them there. We can love them there. We can care for them. It allows us to see, is God already at work? And join him there. Becky Pippert says that evangelism is not trying to start a fire in the middle of a monsoon rainstorm with wet wood and wet matches. But evangelism is the workplace, is finding where God's Holy Spirit has already sparked the flame and just fanning the flame that he has begun. So spiritual history. So, before we have a chance to practice a little bit, questions, concerns, critique, comments, criticisms. And Dave, are you going to be our...
I'll be the mic guy.
So questions. And we're going to do them in the mic because we're recording this for others.
You know, when we have a patient's chart, we document our encounter with the patient, and medically we document their progress. They're getting better, blood pressure is better or worse, and so forth. From the spiritual history point of view, how do we have this tool so we can document their spiritual progress?
Yeah. So the spiritual history is put into the social history. Many, but not all, electronic records have a spiritual history now. The majority of the hospital EMRs now have a spiritual history, and almost all of them, I've not found an exception yet, won't let you freehand in there. So I just actually do the LORD acrostic, and with yeses or nos, and that's my reminder each time that social history pops up of what happened. But you want to document it the same way you would your social history. If for those of you who are on an EMR that does not allow it, then you've got a reason, particularly if it's a Joint Commission approved organization, to go to them, as I did one of the groups I'm working with now, and say, how come we don't have this Joint Commission required? And now, boy, it's done. It's in there. You may come up with your own coding system on how you do that. But for me, it just used to be for years and years, even on the written problem list on our social history, we just had the GOD. And so G would be positive. It was someone who had a personal relationship with God. The O would be positive with some sort of comment if they were part of a particular community. And the D typically would be pray with, would be a positive. We know that's a patient that I can indicate to my partners it was okay for us to pray with in that particular case. So however you tend to want to do it, it's just, you want to be sure if you're going to document it that you document it in a way that's useful each time that you see the patient or people that you work with see a patient. Does that make sense? Yes, so it's document, document, document.
Hi, I'm the quality nurse at my center, and I have a great IT team who will make up a checkoff for my docs when they have to do certain things. One of which was for 65 and over, they would just have to do a drop down and check. And there's no time for them to do that. So I don't get that done very often. So what's going to make them do this? You said it's not that long, but there is no time for them to do in their 15, 20-minute visit what they have to do now. This is just, I can just see them adding on another thing and them telling me, I don't have time to do it. It's another added thing, and they don't have time to do what they want to do now.
Yeah, great question. I have two answers for you. First, I'm going to have my little cynical self. So, your name is?
Judy.
Judy, do you take time to pee? I'll take that as a yes. And why do you take time to pee? You don't have a choice. It becomes a biologic necessity. So when they're telling you they don't have time, what they're telling you is it's not important to them. It's not a necessity. Yeah. But moreover, after tonight, you're telling me that you're willing to accept a 16 to 28% increased mortality. Now you really don't care. Now you're more interested in being a medical mercenary or a medical mechanic than you are in being a medical missionary. Now this is tough love stuff, but this is the questions you have to ask in front of the Lord is, why was I called to this? Maybe I wasn't called. Maybe this is just a job for me. And that's okay. If that's the truth, that's fine. And then you may not want to do it. But the most common lecture that I give in medical schools around the country is on spiritual history. It's because Joint Commission requirements. And atheists and agnostics want to know this. And we in the body of Christ don't? Are you kidding me? I mean, see what I'm saying? But I'll be giving a section tomorrow on the spiritual care team. And one of the things that we're now recommending is that in every care system such as yours, that there be a spiritual care coordinator who makes sure that it's done on each patient as a quality metric. And we'll talk more about the how-tos of that tomorrow. But if you're telling me you don't have time, you're telling me basically it's not important to you. And if that's true, that's okay. But I hope by the end of this weekend you'll see that that's unconscionable for biblical Christians. I just don't see how we can justify that. Is there a counter to that? Am I being too prophetic? And I ask you, brothers and sisters, I ask you not to accept that from me. I ask you to ask Father what his heart is for the people he has brought to you. I'm not saying that in any sort of guilt-provoking way, but whether to ask God's Spirit, what's his heart for the people he brings to you? If these are truly divine appointments, if they are truly divine appointments, how do we interact? And that answer may be different for different ones of us. It's important, Judy. I'm glad you asked. And if you need to go, just go. You can go pee it. We will now.
No, I know she's asking for a very good reason.
Okay. Yes, right here.
Hello, I'm Melissa. I practice pediatrics at West Point. I have a question regarding, sort of when you start asking these questions, sometimes you unearth things that, you might open a big can of worms. And how do you resolve, sort of offering spiritual guidance or things like that when you feel like potentially the person is practicing a religion that is anti-Christ? Let's say they're Wiccan and there's a struggle that they're experiencing. And then, if we're offering, hey, you've asked the question and now it's almost our obligation to provide an intervention, but you feel like that intervention might be against, Christ or against your...
Great question. We're going to spend a whole session tomorrow answering that specific question. What do we do with the reality of time and with some of these questions? But my initial encouragement would be to don't think about that as a spiritual issue. Think about that as a medical issue. In other words, we ask a lot of questions that can open up a lot of cans of worms. We don't deal with all those cans at that visit. We then use the history to prioritize what we need to handle and how we need to handle it. Now, it might be that that's going to become the primary need to be handled today, but typically not. Typically, it's something that we can put off and handle at a later time. And we'll talk tomorrow about how to do that. Great question. Great question.
Hi, I'm Indra Daniels, and I'm a palliative care doctor. And a lot of times the patients' families will tell you up front they want a miracle or they're expecting a miracle. That's even before they know your own personal beliefs. In a situation like that, and they'll tell you, they're expecting a miracle because they believe in Jesus. At that point, what do you as a believer do? Do you keep your faith private? Or do you say, make them know that you're on the same side? And how do you explore this?
Let me generalize that into, rather than a specific question, just if a family or a patient is asking questions about your spirituality, how revelatory should you be or could you be? And I don't think there's a right or wrong answer to that. I think each person has to decide for themselves how they're going to... tomorrow morning, Bill's going to talk to us about open doors and how to respond to them. And this course is not about techniques for any particular situation, but rather to say, how do we bring God with us in such a way that when something like that happens, we quickly, praying without ceasing, get a sense for, Father, how are you leading us? Your question was specifically to me. When someone opens that door, if the timing's right, I'll go ahead and answer that question right then. If it's not right, I'll recognize the importance, but then schedule a time to talk about that later. And then sometimes it may be a question in an area where I don't feel trained or experienced to answer, maybe in the area of miracles, that I would want a pastoral professional or a chaplain to be involved. And so we're going to talk tomorrow about some of those various options so that each of us, including yourself, can decide, Father, how are you leading me to respond in this particular situation? I would tell you that most of the palliative care physicians who have finished this course would see that open door as an opportunity to share respectfully their personal testimony. And tomorrow we're going to actually give you an opportunity to learn how to do that.
Do you think it would be...
We have the mic.
Do you think that if the family says, oh, we want mom...
Wait, just since we're recording, I'm going to...
Do you think that if the family says, we want mom to stay on all these technological devices and everything because we're expecting a miracle, God is going to do a miracle, do you think that it's appropriate for us to then try to convince them that what mom really needs is comfort care?
I think it's extremely appropriate. And the Dana-Farber data, just to chase this very specific question, since you won't let me deflect it right now, because we are running out of time.
Yeah.
But to chase that very specific question, the Dana-Farber data is that if we do not intervene, then outside pastoral professionals will encourage miracle-seeking behavior so that evangelical Christians seeking miracles become the heaviest and most expensive users of interventions that will not and do not make a difference. And so in their particular data set, pastoral professionals, chaplains who are trained in healthcare can help patients wrestle with those issues and begin the process of saying goodbye and letting go, which is not only healthy for them and the patient, but also for the healthcare system. So it's another area where the intersection of appropriate spiritual interventions and medical interventions benefit the patient, the doctor, and the system. This is good medicine. It's good medicine.
So, Walt, just let me jump in real quick, and that is that several of these questions and kind of dilemmas that you have about what to do in these specifics is a great opportunity for a faith story, which we're going to explain tomorrow, and explaining as a follower of Christ what you would do in a similar situation, how you would handle that particular that particular issue for yourself, just as not as directive, but as a faith, showing someone what a child of God might respond, how a child of God might respond in that situation might be really helpful.
Or how other Christian patients you've taken care of have responded to that situation.
Yes.
Just to keep time, I have one last question.
Yeah, what you didn't know is we have another Q&A coming up, but we are now canning that one. So this will be the last Q for the evening. No, go ahead.
So my question was specifically about the referral. You said that if there's any positive, you have to make a referral for counseling or specifically spiritual counseling. What if their faith is Islam or Hinduism? Are we supposed to find specific counselors based on their religion versus whoever we might have in mind?
You know the answer to it. Of course you do. And it's no different than seeking a consult for anything else we do. It's who's the best person to consult for the particular problem that the patient has. And so, first of all, our chaplains in most of our systems are trained to, irrespective of their faith background, to handle patients of any particular background. But you may be in a situation like I am where I know the pastoral professionals, the rabbis, the priests, the monks, the pastors, and I'm able to pick the consultant that's most appropriate for that particular situation. I will tell you, for example, that as I've gotten more experience with the religious struggle question, that can you guess the religious struggle that Muslims have? Now, most of the Muslims I see rank as religious, and so the lab questions in Tulsa where I'm teaching, the Muslims there are running 40-45%. It's a huge deal. And which of the three questions do you think bothers Muslims? L, A, or P? P, it's punished. Almost 90%. And so they trust me. They know I'm a Christian, but they trust me enough to give this difficult information. And I want to meet them, where they're at. And in that particular system, there are a group of chaplains who are very comfortable dealing with Muslim, Buddhist, Hindu patients. And so those are the ones that are appropriate there. We now have a new mental health professional who's an evangelical Christian who's extremely comfortable with those traditions because he comes from a mission background in those areas. And so, but for that, I was just praying, God, who am I going to use? In this area. It's a good question. Yeah. Well, we want to give you a few minutes to practice because we told you we'd be finished at 9, and we're going to, but we've got several opportunities for further questions. So if you have any, write them down because we want to get to them. But what we want to do now is to give you a chance to not use questions as an opportunity to not practice. which we sometimes do in healthcare, don't we? So what I want you to do is just to pair up with someone that you were in group with earlier, and for the first 5 minutes, I want one of you to practice taking a spiritual history from the other one. Use the flow sheet on page 45. And so just go through the questions. Pretend this is a patient and you're just asking the questions and go through them. And for you guys that are patients, answer as if you were really the patient. Don't be difficult, because you're going to be the doctor in a minute. So you've got 5 minutes. So one of you play doctor.